Thank you, Dr. Moores, for a very kind introduction, and thank you for the opportunity. I'm super excited to be the part of the team for this pro-con debate. I always introduce myself as a learner of pulmonary embolism, and I have a passion for PE, and I still try to do that every day to improve my practice in taking care of the patients with pulmonary embolism. I do not have any conflict of interest to this talk, except that I'm going to try real my best to stay on the topic and say, yes, mechanical circulatory support devices do have a role in managing the patients with PE. When we talk about mechanical circulatory support devices and PE, what we are talking about is a massive PE and a high-risk PE. And in my mind, a massive PE, as you can see in this picture, when the entire pulmonary artery circulation is studded with a clot, it's less of a physiological problem, it's more of a mechanical problem. And we know from several studies that RV does not have a reserve to deal with this massive amount of clots or a clot burden compared to what LV could. RV is a triangular shaped chamber which is not meant to deal with sudden surge in pressure that comes with a massive mechanical problem with the clot burden. Also, one may say that why do we need a massive PE as a definition? And I'm glad that recently published European Society guidelines cleared a doubt that massive PE is a spectrum, is not the simple definition that what we were taught in a medical school, that your blood pressure is low for 15 minutes and that is massive PE. Yes, that's true, but that's only one end of spectrum. As you can see on the slide, patients with massive PE can present with persistent hypertension, but they also can present with an end organ hypoperfusion state, in a state of shock. And the ultimate stage and ultimate fear and worry that we have is that a cardiac arrest can be a presentation with massive PE. Unfortunately, one size does not fit all. TPA is referred or is given over 2-hour infusion. When you read the guidelines and in a clinical practice, it's just not practical. I do not have 2 hours to manage my patient who are in a state of obstructive shock and a cardiac arrest. So one size does not fit all here. As I stated, massive PE is a mechanical problem that needs a mechanical fix, and that's not new for us. When we know that when somebody is a severely occluded coronary artery disease, answer is you provide a bypass, you do a cabbage. So same lines, when you have a massive PE with a mechanical clot obstruction, the RV needs a bypass, and answer for that bypass is with the help of mechanical circulatory support devices. So I think I have convinced you enough that I think we need the help of mechanical circulatory support device for massive PE. What we are talking about, how can we bypass that RV? So there are 3 devices which are out there that supports an RV. Some of them acutely, some of them chronically, and somewhere in between. So the picture on the left is, the first picture is of the Protect catheter that is placed percutaneously in a cath lab for patients with a bad RV failure. Unfortunately, this device is not meant for an acute PE-related RV failure. This is more for chronic pulmonary hypertension, end-stage pulmonary hypertension, for other modalities of treatment. So when you talk about mechanical circulatory support devices, Protect Dio is not what we are talking about. Picture on the right is another percutaneous device that can be placed again under the fluoroscopy guidance percutaneously, but needs a technical expertise. It cannot be placed at bedside. It has been well developed and well prescribed in the management of chronic RV failure, but in setting of massive PE, particularly with a cardiac arrest, it's practically not possible. However, small case series have described a potential role of percutaneous impella, which is the picture on the right, that can be used. What I'm talking about in real terms with the mechanical circulatory support devices is a bedside insertion of 2 large cannulas, the V cannula, which is a venous drainage cannula, which drains the blood from the SVC or IVC, puts it through the circuit, oxygenates, and also provides a cardiac output and returns the blood to an arterial cannula to support the complete cardiac output. So in terms of massive PE mechanical circulatory support device, VA ECMO is what we are talking about peripherally. How does it work? Yes, it exactly works the way you want the RV to rest. It decreases the preload because it drains the blood out of your vena cava systems. So it decreases your preload, right? What else it does? It decreases what goes out of the RV. It decreases your RV afterload because the entire circulation is now bypassed on a peripheral VA ECMO circuit. So RV actually gets a chance to rest because you are not dealing with these massive surges in the afterload. And ECMO circuit by itself triggers your intrinsic fibrinolytic system, which may even allow a clot to dissolute without the added need of thrombolytics. So it reduces your preload, it reduces afterloads, and it helps in facilitating the process of clot dissolution. And the guidelines support that. We are in 2020. We are not in 1980s where ECMO was just on paper, or 2000s where ECMO use is debated. In all the guidelines, the ELSO guidelines, ESC guidelines, American Heart Association guidelines do acknowledge the potential role of ECMO in the patients with massive PE. But time is money. Time to ECMO is crucial. Your survival rate goes very down when your ECMO is not instituted right away at the time of the cardiac arrest. Unknown downtime or non-witness cardiac arrest still remains a challenge to consider an ECMO in this group of population. In CHEERS trial, which did not only included the PE patients, but all comers with cardiac arrest, suggested that ECPR team time to arrival versus in people who survived versus not survived was drastically different, and time from cardiac arrest to ECMO initiation was much different in patients with patients who survived versus patients who did not survive. So when you talk about ECMO, what happens if you use an ECMO as a treatment for massive PE? In published literature, it can be used as a sole modality of treatment. So nearly half of the cases in published systemic reviews, ECMO itself provides enough support and time to recover for RV to recover, which is usually 4 to 5 days, and it can be weaned off, and patients do not need any more treatment than simple anticoagulation only. Or in other cases, if you need a patient to have a bridge to a destination therapy or a definitive therapy, like a catheter-directed approaches or surgical embolectomy, ECMO can be used as a bridge to such therapies also. When was the last time you had a patient with a cardiac arrest who went to surgical embolectomy? Or when was the last time you had a patient who had an extremely high absolute contraindication to TPA with massive PE went for surgical embolectomy? Just not possible. You need an ECMO as a bridge to offer those patients such treatment. So if we are at a center and if we have those, ECMO should be your first line treatment for your massive PE, particularly ones with cardiogenic shock. I had the very same questions asked to me, and I was very curious to know, yes, ECMO may be used when people are in that category 1 of massive PE, where they're just hypotensive, you have time to put those cannulas. But what happens when patient is actually in the active cardiac arrest, or cardiac arrest is the presentation from massive PE? And what's an evidence on ECMO on that group of patients? So we performed a systemic review, which is currently under peer review process. We identified 301 patients, and we noted that 61% patients survived to discharge. Again, this has a limitation. This is biased literature, but people also reported, because there is a 39% of patients who did not survive. So even though it's a biased literature, and maybe it's also always published in terms of favorable outcomes, it is being done. And otherwise, these patients are already dead. There is no other options to take care of this group of sick patients. I was curious enough about the practicality of ECMO implementation in the patients with the cardiac arrest, and I wanted to see what determines the outcomes in survivors versus non-survivors. The question that we always get asked is, can you use systemic TPA prior to ECMO? Or if you have given a TPA, can you use ECMO at all? And as you see in the top left corner of the slide, we did not find any survival difference where systemic TPA was used prior to ECMO or not. We noted that older population had a high risk of death. We also did not notice any difference between PE as a primary reason for admission versus it was not a reason for admission and it happened during the course of the disease. And we did notice a difference here where ECMO cannulas, if they were cannulated during the active CPR, those patients had higher risk of death compared to those who achieved a ROSC with the CPR and ongoing efforts, and then ECMO was instituted afterwards. It kind of goes to the fact, the same concept, that when you're in active cardiac arrest, your goal should be achieving uninterrupted CPR and achieving a ROSC. And by doing so, to achieve a ROSC, if you think that as a part of ACLS algorithm, TPA makes more sense, use it. And I think that's what also this study, our study, reflected. So we performed the multivariate analysis as predictors of mortality, and our findings held true for the older patients had a high risk of mortality, and cannulating the patients after achieving the ROSC had a higher success of survival. So in a nutshell, I would say VA ECMO has found its place. Time to ECMO is extremely critical in patients with massive PE. Earlier the better. ECMO can be used as a bridge to recovery or combined with a PE-specific therapy. And I am not by any means suggesting that TPA should not be used if you have ECMO as a part of your treatment plan. Rather, focus on achieving the ROSCs and then consider a very early use of ECMO if you can save your patient's life. I'll stop there. Thank you.